Rick wears two hats in the research world, though. He's also the director of research in the Osher Center for Alternative and Complementary Medicine, where he's done really some very exciting research on understanding diet and exercise and the complementary aspect of medical approaches to our patients' lives. And I think it may not be too strong to say that I begged Rick to give this talk, because I feel like we all spend so much time trying to tell our patients how to incorporate healthy diet and exercise into their lives. We know this is such an important part of keeping healthy and living a long, healthy life. And I feel like I, for one, do a terrible job of it. And so I wanted to see if Rick could share with us the knowledge that he has from an evidence-based perspective on what diet and exercise interventions work so that we can have better tools to really educate our patients. And I can think of no better person to do this than Rick, who's really actively engaged on a number of levels in research projects to understand how we can do a better job of providing these interventions for our patients, both HIV-infected and HIV-uninfected patients.
Thanks, Annie. I want to say two things before I really get into this. One is, I am going to talk about diet and exercise. I changed the title to really focus on diet because as I started putting all the talk together, there's just so much material that I felt like I needed to focus it more on one thing. So the thing I'm primarily going to be focusing on is diet. I'm going to give you a little bit of work with exercise at the end. And if you're interested, you want to hear more, then maybe I'll negotiate with Annie and we'll do another talk sometime next year and focus more on the exercise part. The other thing I wanted to say is I want to make this maybe just a little bit more informal than our usual HIV grand rounds. If you have questions as I'm going through, feel free to call out. We'll have time at the end, hopefully, too. But if there are key things that are coming up as I'm talking, I want to invite you to raise questions and issues as I'm going through this. So, in thinking about putting together this talk, this is one of the places where it really made me think back again to the early days, for those of us who have been doing HIV care for a lot of years, of what things were like when I first started doing HIV care. Part of that was I did 2 years in the 1980s and early 1990s at Montefiore Hospital in the Bronx as an AIDS attending. And I remember, it felt like coming out of a war. Every one of my patients died. Each week it was, how many people will have died? And that was so much the focus of our work. We're clearly in a really different era right now. But there are these remaining questions. Our patients are not all dying of immunosuppression. But we have to think then about what are some of the key issues and what are our patients dying of now. And that's why I think some of this, even though it seems much more mundane, is some of the key issues that we need to be working with patients now, diet and exercise, which in some ways is a luxury. It's very different than what we had to deal with 20 years ago. But I wanted to ask a question just in starting this. This is partly just to get feedback input. There's no right question, right answer, obviously, here. What I want to know is for those of you who are clinicians, thinking about your patients who are on HIV treatment, what are they dying of? Not the people who are going off treatment. Most of my patients in the last 15 years who have died are ones who've, for various reasons, gone off treatment or didn't stick with treatment. But for those of you who have patients who are dying on treatment, what's the most common cause? So just going through these choices, let's see. Okay, so the number one thing that it sounds like people are saying here is cardiovascular, with liver disease being quite high and cancer being significant too. So that really matches my experience. When I've had patients dying now who are on treatment, the majority of them really are dying of cardiovascular disease, whether it's a heart attack, a stroke, or some other kind of cardiovascular issue. So I was wondering if this would be the case, but part of why I'm looking at this is to frame this talk, because some of the issues we're talking about really are most pertinent to things like cardiovascular disease. So the thing here that's interesting is if you look at what national data is on the general population, the number one cause of death is heart disease. And if you add stroke as another form of cardiovascular disease, that's even greater. So to me, one of the key things that's left when we talk about patients on treatment right now, what do they die of? Cardiovascular disease is a key thing. And one of the issues, which I'm sure almost all of you are aware of, is cardiovascular disease is probably an even bigger issue in people with HIV than it is in the general population. This is just one piece of data, which is a fairly large set of data that suggested that the relative risk of cardiovascular disease in people with HIV compared to the general population is about double. And that's a strongly significant difference. Now, we're going to come back to this. There's a variety of reasons why this may be true. Peter Hunt talked about this in his recent grand round, so I'm not going to go into it in depth. But clearly, one of the issues is increased inflammation. We're going to come back to that at certain points. OK, so what I'm going to focus on first is the issue of looking at diet and lipids as they may relate to cardiovascular disease. And I'm going to make one assumption, which is, at least as a general rule, hopefully what applies to people without HIV for this issue is going to apply to people with HIV. Now, that is an assumption. It ideally needs to be proven more, but we just don't have great data on that. I'm also going to give you one caution, which is that some of what I'm going to be talking about is controversial. I'm going to highlight that at points. It also turns some of the dogma that at least many of us, and I am one of them, have been trained in on its head. So some of this is going to look different than I think some of you have been trained in. So just be prepared for that. OK, so I want to ground this in a patient. This is one of my patients from my clinic. This is a guy who's in his 50s. He was diagnosed with HIV about 15 years ago. He's been on treatment for quite a while, although he had a lapse for several years where he went off, came back in, got put on a ritonavir-darunavir regimen. His CD4 count had dropped a lot when he went off treatment, and it hasn't recovered very quickly. So he came in with a CD4 count of 160, but with an undetectable viral load. He has a family history of cardiovascular disease. He's not a smoker. His BMI is 23. He has hypertension, but it's treated in a target range. He already has high triglycerides, and I'd put him on gemfibrozol for that, which had an effect. But despite that, this is his lipid panel. So I'm going to go through this, and as I'm going through this, you're going to get some questions about how you look at lipid panels. So think about this. So here's his lipid panel. He's got a total cholesterol of 261, an HDL of 36, LDL 154, and triglycerides still quite high, 354. So here's the question. When you are looking at a lipid panel, how are you using that information? What of those measures is the best predictor of cardiovascular risk or development of arterial sclerosis? Is it total cholesterol, high LDL, low HDL, a high triglyceride HDL ratio, or a high total cholesterol to HDL ratio? So if you're going to pick one of those numbers using this information, which one is the best predictor, if you have to pick one, of cardiovascular risk? Okay, I've got a few more people coming in. OK. All right. OK, so this is really interesting. OK, so half of you picked high LDL. Almost no one wanted total cholesterol. Low HDL, a small amount of people, and then the rest of them are these ratios. So I'm going to go through some of the data on this, and this may be a little bit surprising. So there is a lot of data actually on this right now. This is one of them. I think it's a nice set of data. It's from a large cohort study. This is a women's study, but it translates reasonably well into men. And this is looking at a series of the markers, including the ones that most of the ones we just covered. And it is looking at what the hazard ratio is for cardiovascular disease based on this measure. So here, LDL, which half of you picked, that is the worst measure. That has the least predictive power for cardiovascular disease. The ones that came out better, so total cholesterol came out a little bit better. HDL is significantly better. And this comes out in study after study that HDL cholesterol is actually a better predictor than LDL of cardiovascular risk. What's even slightly better here is the non-LDL cholesterol. So that's you take the total cholesterol, subtract the LDL, and you get what's left. So that's HDL plus what's in triglycerides. The other thing I'm going to highlight here, this is not a lipid measure, but this is important, is high sensitivity CRP. So this is really a measure of inflammatory state. This comes out better than any of these lipid measures. And we're going to come back to that at certain points. The final thing is ratios, okay? So here is a ratio, total cholesterol to HDL. So that was one of the choices there. This is better than the rest of all these lipid measures in terms of the strength of prediction of cardiovascular risk. So that's one measure. That this ratio was not reported in that study, but this is another one of the ratios. So this is triglyceride level over HDL. And if you look here, this is the relative risk of having a myocardial infarction in a large study comparing cases with myocardial infarction against community controls. And you can see there's an incredibly high relative risk here. If you're in the upper quartile of that ratio compared to the reference, it's a relative risk of 16. This has come out in a number of other studies. So these two ratios are probably the best predictors of cardiovascular risk, either the total cholesterol over HDL or the triglycerides over HDL. Okay, so to think about this a little bit more, I actually think one of the things that's useful is to be grounded in what is, in a sense, a newer concept, which is metabolic syndrome. So a question here is, I think most of you are going to be familiar with this, but the question is, if you're looking at what the components are of metabolic syndrome, which one of these is actually not a component of metabolic syndrome? Is it elevated blood pressure, elevated fasting glucose, high LDL, high triglycerides, or low HDL, sorry. Okay, so if you're not sure, it's all right. Just take a guess now. Okay. I'm going to see what people think here. Okay, so you've got some clues because I've already been talking about this. So at least a third of you picked high LDL. So that's actually the answer. The rest of these are components of metabolic syndrome. The thing that is not is LDL. So this is coming back again to how we're looking at the lipid panels. If you think about metabolic syndrome, the definition actually does not involve LDL. It does involve HDL and it does involve triglycerides. So let's look at this just a little bit more. So these are the definition. This is one set of definitions. There's a few of them. This is, I think, a pretty accepted one. This is the updated American Heart Association and National Cholesterol Education Project definition. So a few things to highlight. So one of them, it does not have obesity, although obesity is tightly linked to this. What it does have is elevated waist circumference. And the reason it has this elevated waist circumference is that the thing that we think is probably driving metabolic syndrome is not just being overweight, but it's where the fat is. It's central adiposity or increased abdominal circumference as a kind of fairly crude measure of having a lot of visceral fat in the abdominal cavity. So it's got cutoffs here. The next thing is elevated triglycerides. So the cutoff is above 150. Or low HDL, and the cutoffs are different for men and women. 40, below 40 for men, below 50 for women. Another part of this constellation is elevated blood pressure. And a final thing, which is really actually key down here, is the elevated fasting glucose. So there are different measures of this, but the reason this is important is what this is actually getting at is insulin resistance. And the reason that that is important is that in the pathophysiology here, one of the things that is probably driving all of this is insulin resistance. That's probably, while there's still some controversy, it's probably a central driving factor here. And it is linked probably to all these other things, including the lipids. So if you think about diabetic patients, those of you who have worked with this, one of the characteristics of patients with diabetes is elevated triglycerides. It tends to go along with insulin resistance. So it's part of this whole constellation here, and it also tends to go along with low HDL. Okay, so let's come back to this patient. So my patient, you might remember, had an HDL of 36. So this is below that cutoff for metabolic syndrome. This is really a continuous thing, but it's clearly he's in the bad zone here. His triglycerides, there's just no question, he's like twice what you'd want for the cutoff for metabolic syndrome. He's already on all these HIV medicines. He's taking gemfibrozol. He does not want to take anything else, he says. So his question is, what can I do with my diet? So this, I'm going to bump to the audience. So I'm going to give you a few choices here. You have a patient like this. What would you actually recommend if he says, I want to deal with diet? Would you say, put him on a low-fat diet? And this is kind of a breakdown of a kind of fairly common low-fat diet. Would you try and get him to cut way down on his carbohydrates, down to only about 15% of his calories from carbs, with quite a bit of fat? Or would you have him somewhere kind of in between, what might be a more conventional diet? Or would you just tell him, forget it, there's almost nothing you can do with the diet, don't worry about that, let's do something else? Okay. All right. I'm going to get final answers. Okay, so. All right, so this is interesting. So this is where, I'm going to warn you, this is where this is going to go against the dogma. So most of you picked a low-carb diet. Picked a, yes, actually, yeah, a low-carb diet. So this is interesting, and I'm actually pleased that so many people would pick that. We had 22 people picking a low-fat, 22% with a low-fat diet or in between. So. And no one thought you shouldn't worry about the diet. I guess that's because you know you're at a diet talk.
So you don't have the Mediterranean diet on?
So I didn't say this, but okay, I didn't use this label. I didn't do that for a reason. Is this C, the in-between? That's actually a breakdown of a fairly typical Mediterranean diet. So that would kind of match a Mediterranean-type diet. And I wanted just to start with this kind of the macronutrient part. Okay, so let's go through this. So here's some of the data here. This is one piece of data that I think is really important, and this is Mediterranean diet data. So do people know this? The Predamid study was over 7,000 person study done in Spain, with the main outcomes reported last year in New England Journal. It is, I think, one of the most impressive diet studies that's been done so far, both because of the scope and the results, I think, are really important for practice. So the primary outcome here were cardiovascular events, either heart attack or stroke. And what they did was compare a control diet. So the control diet is essentially what the American Heart Association has been recommending for years, which is a low-fat diet for heart disease. The comparison diet was a Mediterranean diet broken down into two groups. One group, they tried to boost up, everyone in the Mediterranean diet was advised to use lots of olive oil. One half got an extra olive oil supplement, the other half got an extra walnut supplement. So they kind of broke down the nuts versus the olive oil groups here, which looked pretty much identical here in this key outcome, this is the primary outcome, cardiovascular events. The control group here, you can see, by 5 years, has substantially more events. There's about a 30% or greater reduction in cardiovascular events in this group. It was a generally high-risk group. it was a strongly statistically significant difference here between groups. So there's this reduction in cardiovascular events using a Mediterranean diet. And the thing I would point out is this is a higher fat diet. People didn't do great following the low-fat diet. It's one of the critiques is that maybe if they followed it better, they would have done better. This is the real world. This is what people are following when they're trying to do a low-fat diet. And overall, the low-fat diet group had lower fat content in their diet. The higher fat, essentially, group on the Mediterranean diet did better. So this has really kind of changed this whole dogma that has been around for a lot of years that for heart disease, you should really be getting as low a fat diet as possible. This is saying that at least some fats are probably good from the cardiovascular standpoint. And the next question is, for our patient, my patient had dyslipidemia. So there is a clear benefit of the Mediterranean diet for that group. If you look here, if you didn't have dyslipidemia, there was not a really clear benefit. Here, this is on this side here means the Mediterranean diet is better. The group that really benefited were the people who had some amount of dyslipidemia. So applying this to my patient, he might benefit from a Mediterranean diet if you're trying to prevent cardiovascular disease. Okay, so looking overall at metabolic syndrome, the question is, does the Mediterranean diet help? And this is just using a cutoff. Do people meet criteria for metabolic syndrome, yes or no, comparing the diets? And really, I would say the olive oil and nut group did fairly similarly, but the nut group tended to do a little bit better. And it had a statistically significant decrease in metabolic syndrome compared to the low-fat diet, which essentially didn't change between baseline and 1 year. So the next question is, let's say you're trying to get your patient to do this. What do you actually do? What do you say to them? How do you work with this? So this is from the table in New England Journal that outlines the diet. And I actually think it's a fairly helpful guide because these are things we actually can work with our patients on. You go through these kind of steps, and this is one of the things I do with patients. So one of the things is to increase what we know are healthy oils, and that's olive oil, or I think the thing that can be substituted, which is less expensive here, is canola oil. It has a fairly similar makeup, and there's other data on it that suggests it has some of the same effects. So using oils like olive oil or canola oil, using them liberally. Tree nuts and peanuts, I would probably focus on the tree nuts here, although peanuts are probably okay, but there's not as good data, I think, on that. And then fresh fruits, vegetables, fish. This is not tons of fish, but it's more than I think most of our patients would do, 3 times or more per week. Legumes, so frito. So this is basically like a tomato sauce with onions. And then white meat, things like poultry. And then here's one of the good things, maybe, for some of our patients is wine with meals. It's optional, but 7 glasses a week of wine. There's another part which I think is equally as important, which is these are all the things that are good, and you can advise your patients not just get rid of this, but these are the things to eat. But there is a set of things you want to work with cutting down with this kind of diet, and actually almost any of these kind of diets. So that's sodas, and I'm going to highlight that as kind of culprit number 1. Basically, commercial bakery goods, sweets, pastries. I'd include a lot of kind of junk snack food in this category here. So those are 2 things that they really cut out here. Okay, so the question then is just to really focus in on the issue with my patient. Probably the biggest issue was his elevated triglycerides. How well does this diet work then for triglycerides? So here's the data actually from the Predimid study. So the group with olive oil, they had elevated, 31% had elevated triglycerides at 1 year on the diet. People on nuts did a little bit better, 28%. On the low-fat diet, it was 35%. So this was almost but not quite statistically significant as a difference. But remember, this is like a 7,000 person study. So looks a little better, not going to overwhelm you in terms of improving the triglycerides. So the question is, anything else you want to look at? So I'm going to go through a little bit of this data, and I will tell you, I have had to struggle with this data. This is, it's over time kind of won me over, but my background, before I actually really delved into this, I've been a vegetarian basically for about 40 years, eating a pretty low-fat diet and advising my patients to have a low-fat diet. Well, that is fairly different than what is being studied here. So this is an article that I remember when it came out in 2003. It was one of the early, really kind of well-done big studies looking at an Atkins-type low-carbohydrate diet. And it was focused on people with obesity, but I'm going to give you the triglyceride data here. So the change in triglycerides on the conventional diet, up very slightly. The change in triglycerides on the low-carb diet, down 22%. So this was really statistically significant as a difference. So much bigger impact here than we were seeing from the Mediterranean diet. So here's a little bit more of the data here. You can see I gave you the 3-month point. This is the triglycerides out to 12 months. So by 12 months, it actually looks even better. It's a 28% decrease. The other thing I'm going to just highlight here is, so the other thing we've been talking about as significant besides triglycerides for metabolic syndrome is HDL cholesterol. So what happened with that? The HDL cholesterol here went up about 20% versus a much smaller change in the conventional diet. So this is actually benefiting not only the triglycerides, but the HDL. So what did I do with my patients? So I'd been working with this data for a while. So what we talked about was actually going on a low-carbohydrate diet, testing that, see how it would work for him. He went on it, and at 6 months, the key thing here is his triglycerides dropped from 354 down to 200. So that is a big drop. The thing that didn't do as well as I would hope is his HDL essentially stayed stable here. But for triglycerides, this worked, at least for him, really well. And I'm going to emphasize one of the things here, which is that there's a fair amount of variability between individuals. And this is one of the things we have to take into account. I don't think with all of this stuff that one size fits all. You have to think about your patient not only in terms of their kind of psychological issues, what they're ready to do, what's going to work in their lifestyle. You also have to think about how this is going to work for them metabolically. And sometimes we have to actually work with a diet, do lab testing, and see what's really working for them. Okay, so if you're going to do this, if you're going to try a low-carb diet, I'm going to not go through this in detail because it actually would take, I think, longer than I could spend here to really work through everything. But I'm going to give you a few kind of ideas of what this looks like. So the first thing is to work with patients to read labels. So all our foods that are labeled have the amount of carbohydrates in it. What you want to aim for is about, ideally for a really low-carb diet, around 50 grams of carbohydrate per day, really under 100. But this is going to vary according to the patient, what they're trying to accomplish, and so on. The key thing to know on the label is you subtract out the fiber. It's included in the total of carbohydrates. It does not count. It does not do the same thing that the rest of the carbohydrates do because it just passes through you, and it's actually desirable, not undesirable. So to get an idea of the true carbohydrates that you care about here, you have to subtract fiber. In general, and this is one of the things that, at least for me, was tough, you have to think about if you're cutting down on carbs, you have to replace it with something. What you have to replace it with is fats and protein, and you actually don't want just protein. People who go on really high protein diets, they're actually substantial risks. You want to actually have fat in there also. So a general idea is don't limit fats. The thing you want to cut out or reduce are these things. So again, some of the same stuff as we saw in that Mediterranean diet study, you want to cut out, particularly sodas, I think is a number one thing. Just you got to cut that out if you're going to get anywhere near doing this kind of diet. Sugar, sweets in general, fruit juices, which are actually quite high in sugars. In general, grains you want to limit or cut out entirely. If you don't cut them out, just use them sparingly. And potatoes actually fits in the same category. There are fruits that you want to be somewhat careful with. Bananas are actually very high in carbohydrate. Stone fruits, things like peaches, plums are fairly high in carbohydrate, and melons. And actually milk has a lot of lactose, which is, again, a sugar. What you want to eat is lots of nuts and oils, poultry, meat, fish. You don't need to go for lean cuts on this kind of diet. Lots of vegetables, it works well with this. Really, the non-root vegetables, especially things like green leafy vegetables, lots of salads. Tofu, unsweetened soy milk works with this. Cheese, whole fat yogurt. Yogurt, actually, even though it looks like it has a fair amount of carbohydrate, a fair amount of it is actually broken down by the culture so that it's lactic acid and not lactose, which again gets around this issue of the effect of sugars. And then for fruits, things like berries actually are the lowest in sugar and don't enter your system as quickly. So if you're going to have fruit, things like berries. Okay, so that's kind of the basics of the diet. I can, for those who are interested at some point, I can go into that more. Yeah. Okay. So rice, in terms of grains, actually, the whole grain brown rice is probably one of the better grains. The basic idea, and I've gotten this from nutritionists, is if you're really talking about whole grain, ideally what you're talking about is truly a whole grain as opposed to whole wheat flour, which is a ground up whole grain. It turns out, and I'm not going into this a lot, but one of the underpinnings here is this idea of glycemic index or glycemic load, and that is how fast a carbohydrate enters your system and bumps your glucose level up. And there's very little difference, it turns out, between white bread and whole wheat bread, which was very dismaying for me because I love whole wheat bread. But what's lower down, substantially lower down, are things like brown rice. Or another example is farro, which is a whole wheat. It's used a lot in Mediterranean diets. It's an older variety of wheat that's a little lower in carbohydrate in general and is the whole berry, and you cook it up. And again, those enter your system more slowly. They don't give you this big bump in glucose, which is one of the underpinnings that's probably behind some of the problems here that that some people get with high carbohydrate diets. Yeah.
I think I probably speak for a lot of us when I say that it's remarkable the level of nutritional counseling that you're able to provide to your patients, and that mine, if I started talking about carbohydrates and counted up, I mean, I'm really focused on very basic nutritional stuff, and even then I get the glaze over. The nutritional literacy level of the folks we're often talking to is very, very low. And are you able to say, okay, 50 grams of carbohydrates? I mean,
so it may be partly some of the patients who get sent to me, but I actually have had a remarkable number of patients who are actually interested enough in this to start really working with it. And it's definitely a lot of patients who they're not going to go into this, but the thing that helps, at least I think for me, for some patients, is tying it into something they care about. And it's either they're overweight and they want to lose weight, or they're worried about their heart disease risk. So the patient I was showing you there was worried. I mean, he's got this family history of cardiovascular disease. He doesn't want to have it happen to him. So tying that in, like, this is something you can do. This is something where you might have some control over your risk. That's worked, but definitely doesn't work for all my patients. So this has to be really geared to what the patient's interested in. Okay, so the last thing, this is kind of the closeout of the triglyceride part, is what else you can do. So the other things that help that are non-pharmacologic, and remember this patient didn't want more drugs. Exercise helps lower triglycerides and omega-3 fatty acids. So that's either, you can get in several ways. From fish oil, capsule supplements, or flaxseed. So those are other options here, or things to do in addition to what we were talking about with the low-carb diet. Okay, so I'm going to move on to a second, somewhat related topic, which is obesity in our patients. So This is, I don't know about you, but this is actually now an issue. It's very different than 20 years ago, but now I'm worrying about my patients who are obese, and they're getting upset about it. So this is one of my patients, a 60-year-old guy who's been on treatment since 1995. His weight is 110, and his BMI is 30. So we get, when we use Hero, we plug in the weight, and we get this nice BMI calculator. Do any of you look at the BMI part? So the question is, how do we think about that information? And I think a lot of you are going to know this, but just to check. So what's the cutoff here for considering someone to be overweight based on BMI? Is it 20, 25, 30, 35, or 45? Okay. So yay. So most of you got this right. So above 25 is considered overweight. So here are the categories. So underweight, where we start worrying about people, is under 18.5. The normal is between that and 25. Overweight, 25 to 30. So you start beginning to get concerned about the weight. And obese is a BMI of 30 or greater. So my patient, remember, he was 30.6, I think. So he's just over into the obese category now. So the next question is what you would recommend. And actually, I'm going to say that I don't think there's one right answer. I'm interested in what you're going to pick here. So this is, again, the same choices, the low fat, low carb, or in between. And this is, I actually am thinking, as we talked about earlier with Dan's question, Mediterranean type diet. Or you tell them, don't worry about the diet composition. You just got to worry about your calories. Okay, so let's see what people picked. So, wow. So we got a pretty even split between a low-carb diet or in-between kind of Mediterranean diet. So this is actually what I would pick either one of these. So let's go through the data on this. So this is one nice study. This is a study that was done in Israel. It was a 2-year trial. It was done at an isolated workplace where they had a cafeteria and they could make sure people ate exactly what they gave them. They couldn't control what people ate outside the cafeteria, but they said in Israel, lunch is the biggest meal, so if we can control this and work with everything else people are eating, we're actually really controlling the biggest meal of the day. And they randomly assigned a little over 300 people who were obese to either the low-fat, calorie-restricted diet, a Mediterranean calorie-restricted diet, or I'm going to emphasize this, a low-carbohydrate, non-calorie-restricted diet. So the first two involved calorie counting and restricting calories. This did not involve calorie counting on this arm, and that is typical of what's done in a lot of low-carbohydrate diets. So what did they find? So this is the weight loss outcome going out to 24 months or 2 years. So the red line is the low-fat diet. This is the Mediterranean diet, and this is the low-carb diet. So I'm going to point out a couple key things. So first, it doesn't look like the low-fat diet did as well. And statistically, that was very strongly statistically significant, less than 0.001. So there is a whole controversy, and there are some people who are emphasizing right now that the key thing is just adherence to diet. And I think that is a really, really important point. But I think, personally, I think we have data that suggests that ignoring the diet composition probably is not ideal, and that the low-fat diet that has been recommended for years is actually probably not as effective in losing weight for most people. And this varies from individual to individual, but in general, this does not work as well. The low-carb diet here clearly worked better at 6 months here. And then there was a trend back upward. So one thing that you might not know is this was actually following a kind of Atkins diet formulation, which calls for a decrease in carbohydrates most in the first few months and then backing off on that. So part of this may be trouble adhering to this long term. It also may be that essentially the prescription is to start increasing carbs. And that weight happens shortly after the increase in carbohydrate content. So that's something to keep in mind. Overall, though, these diets, the low-carb and the Mediterranean diet, looked pretty similar. This is another study. This was done by a group at Stanford. So this is to give you kind of one more perspective on this, also to show this is not just one fluky study. So they compared 4 diets here: the Zone, the Learn, the Ornish, which is a very low-fat diet, and the Atkins diet, which was their representative low-carb diet. So the Atkins diet is in the triangle here, and you can see here it did better than the rest of these diets, and that was statistically significant. And actually, no, the people who did this trial were not Atkins diet fans. In fact, they were more kind of doing this to show that it probably didn't work as well, and got surprised by this result.
Is there any account for body mass index and proportionality of weight distribution as well as body type when making these considerations?
So, okay, so the question is there any consideration of body type here with looking at this, and like where the fat is distributed and so on? So that's not directly addressed in this data. There's data that I think is still actually unpublished from this that suggests that the people who benefited particularly here or most consistently were people who had some degree of insulin resistance, which goes along with central adiposity. So my thinking with this is an issue where if you have trouble handling carbohydrates, meaning that you have some degree of insulin resistance, that's where you're probably going to benefit most from this. If you don't have that, it may not make so much difference if you're using this. It may not be a bad thing. It may not work against you, but the benefit is probably particularly in people who have some degree of insulin resistance. So the last thing I'm going to go through here is something that really starts to tie it back to our patients, and that has to do with inflammation. So remember, I noted this at the beginning. This is something where we focused on this on other HIV grand rounds. One of the key issues probably with increased cardiovascular risk in people with HIV is increased inflammatory state. One of the good measures of that is high sensitivity CRP. It works in the general population. It works probably even better as a predictor of cardiovascular risk in people with HIV. So what happened to CRP on these different diets? So the low-fat diet here had a slight decrease. The Mediterranean diet, intermediate, the best decrease was on the low-carb diet. Now, these have to be interpreted cautiously. They were close to statistical significance, but not quite. So you have to take that with a little grain of salt. But this is actually a fairly substantial decrease, a decrease of 1.3 milligrams per liter. So this is not a trivial decrease. This is, at minimum, reassuring that this kind of low-carb diet in our patients probably is not going to make inflammation worse, and probably is going to make it better. Now, I'm underlining this in part because I've had this debate with Peter Hunt, and I think he mentioned it a couple weeks ago in his grand rounds. He has one study of a handful of people who are HIV negative who were fed one meal with heavy cream, and that a few hours afterwards led to increases in IL-6. And Peter has been concerned about that, indicating that eating a really high-fat diet is going to bump up your inflammatory state. This is data that I think is much more relevant. It's long-term data, people on real diets, not eating just drinking heavy cream, which I think most of our patients wouldn't do. And I think it actually suggests that over time, this probably is associated with a decrease in inflammatory state. And there's several other studies that get similar kind of results, decreased CRPs on long-term low-carb diets. Okay, so back to my obese patient. So when I started going over diet, and this is someone, back to Annie's question, this is not someone who's jumping up and down, wants to know all about measuring carbohydrates and stuff. But what I did do, which I find useful, is to really go through carefully what he ate over the last 24 hours. And this actually took some prompting because I did not get it until I started asking him, and are you drinking any sodas? It finally came out, and after a little bit of probing, that he was actually drinking 4 to 5 sugar-sweetened sodas per day. And going over all the diet, we worked at, as kind of the key thing, cutting out sodas and other junk food. So in terms of what can be done with most of our patients. If they're consuming sodas, a simple thing is just get them at least to switch to a diet soda. We can argue all you want about the sweeteners and stuff like artificial sweeteners, but as far as I'm concerned with someone who's obese or has insulin resistance, it's better to be on a non-sugar sweetened soda than on a sugar sweetened soda, or in this case, we got them drinking water more. We worked to cut out sodas and other junk food and made a few modest changes toward the Mediterranean diet and got him walking more. And what happened? So this is not totally dramatic, but it's meaningful. He lost 7 kilograms over a year. His BMI decreased from 30.6 down to 28.2. So that's something, at least for me, that's worked with one of my patients who, again, was not someone who was ready to dive into a lot of diet stuff. Okay, so summary here. So one of the things that I would recommend is just this thing I just mentioned is when you're working with any of these things with your patient, it takes about 2 or 3 minutes. Ask them what they ate over the last 24 hours. What did they actually have for the meals? What did they have in between? Are they snacking? Are they drinking sodas? Start if you pick up that they're consuming sodas or processed snack foods. That's a kind of a first thing to work with. Individualized diet recommendations. We've talked about some of this. This has to depend on both what the patient is ready to do and what might make the most sense for them metabolically. If you're looking at decreasing cardiovascular risk, your patients are concerned about that. I think the strongest evidence now is for the Mediterranean diet. And I showed you some of the key data. There's other studies that back that up in patients who already have cardiovascular disease. The low-fat diet, I think, is really out. And that's kind of one of the messages I'm giving here. Even the American Heart Association, which has been promoting this for years, has changed their recommendations on this. If you're looking at weight loss, depending on the patient, what they're up for, whether it looks like they have insulin resistance, like they're pre-diabetic, either a Mediterranean diet or a low-carbohydrate diet may be best for weight loss. The one advantage of the low-carbohydrate diet for some patients is it doesn't require calorie counting. One thing to know is if you go to Weight Watchers, if you send your patients there, they do have a separate kind of approach, which is essentially a low-carb approach. So they can work with Weight Watchers either with just calorie restriction or with this low-carb approach. And as I was been noting, the low-carbohydrate approach, if you're going to pick between these, might have advantages in someone with diabetes. Finally, there's at least some evidence that decreasing carbohydrate intake may decrease inflammatory states. So for some patients, that's going to be a motivation. If they're concerned about their cardiovascular risk, this may be something that's going to help a little bit. Okay, so finally, I'm going to take just a couple minutes, and I'm making this the really condensed version on exercise. So there's a whole bunch of things I'm going to go through this really quickly that we think are benefits, right? That it predicts better weight loss maintenance. There's a bunch of data that suggests it decreases markers of inflammation, which again, I think I'm particularly concerned about with my patients. There's great data backing up that it decreases cardiovascular risk. The question is, what should we be recommending and how do we actually get patients to do this? So there are two things. So one piece of data here, this is a pretty big study that was done by Tim Church in diabetics. And the question it was asking is, if you have a limited amount of time, is it better to just do aerobic exercise? Is it better to do strength training with weights or both? If your goal is to improve your insulin resistance. So this is a key question in a lot of our patients who have metabolic syndrome. So here, the key thing here is this group here, down here is the combination. So they exercise same amount of time, but they got better results with their hemoglobin A1C if they had both aerobic and strength training. So the message from this is if you can actually get patients to do this, some combination of aerobic and strength training is probably best, at least from this kind of perspective. The other thing, just a piece of data that I work with is this issue of, do pedometers, or now the new thing is accelerometers, help at all? And the basic data is, I think, modest effects, but they can make a difference for some patients. So this is data from a meta-analysis which showed that in general, looking at a control comparison across a lot of studies versus using a pedometer, patients who got the pedometer did increase their walking more by about 2,500 steps per day on average. The things that helped within that were having a goal like 10,000 or more steps per day. This had other health benefits, so we weren't just getting people walking. It actually did things like decrease blood pressure. Now, and I just have to mention this really briefly, so this was done, most of these studies in the days before we had good, cheap accelerometer devices, things like Fitbits. So they are probably more accurate than pedometers. They give you distance as well as steps. So that's one of the things, for a patient who's up for it, you can think about doing that. The thing that's really coming out, and this is going to change over the next few years, is smartphone apps that can track activity. And the big change here is that the new iPhones and Android phones have essentially a low voltage accelerometer built in that will run all day without wearing your battery out. So instead of carrying an extra device, you can put an app on your phone. This is just coming in, but if your patients are like mine, a surprising number actually are using smartphones, and over the next few years, they're going to be able to use these kind of apps rather than buy some other device. So that's the key recommendations. Again, the summary here for exercise is gear it to your patients. If possible, combine aerobic and strength training. And what I've worked with is actually the YMCA in San Francisco does a sliding scale. They've been pretty good about working with that with patients if I can get the patient to go there. Set goals and follow up with your patient. Ask them if they're actually doing what you plan to do. Walking is a great form of exercise that's accessible for nearly all our patients. And if you do that, consider some kind of thing that's going to help them track and then go over what they're doing with you. Thanks.